This is a topic on functional vocational rehabilitation. It's a very complex, more detailed than a full hour could even cover it. So I'm just gonna highlight and just give a broad spectrum on what it is without going into the real big details of it. Basically, we go through the functional rehab portion of this, which is defined as patterns of motion that uses multiple joints acting in various axes and multiple planes, basically the movement of the body. Then it is usually complemented with your traditional rehab, where you assess the patient's ability to do a certain activity, function, or work capacity. The succession of these activities that stimulate the actual motor, vocational, or a sports skill. It could be related to not only a work injury that you're assessing them, it could be a sports injury from any athlete as well. So this is a general board definition of functional rehab. We're not just focusing on what we see normally as a patient, but it could be also related to your general sports injuries, from a high school football player to a middle school baseball player to your professional athletes. It's basically to enable the patient to acquire or to reacquire a skill that is needed to be performed, whether it's their work job placement, whatever they're doing at work, or whether it's a sports skill, whatever is their skill that they had acquired an injury that needs to be re-taught or reattained. So basically the benefits of using functional rehab, which is basically to reach the patient's goals. The goals are restoration of the joint range, restoration of strength, restoration of the proprioception, restoration of their agility, restoration of confidence. And confidence is really big. That comes from psychological and psychological type of benefits to the patient. Let's say they had a knee injury while they were working and they tore the ACL. A person who was walking, lifting a patient, or had a low back pain and ended up having back surgery. Now they're always going to have a fear of going back to work. Or the patient who or a person who was walking and injured and ruptured the ACL is going to have problems with their ability to walk. And also, most important, if a patient had like an ACL or a knee injury, you have to restore their proprioception, the ability to understand, to walk, to not fall, to gain their balance. So there are phases in functional rehab. Phase 1 is, of course, the acute phase. Then you have the repair phase, and then you have the remodeling phase. The remodeling phase is a focus on restoring back to prior to the injury, basically trying to get them back to be functional in society, back to their jobs or back to their position as a professional athlete, whatever they were doing, back to what they were doing before. Am I going too fast? You okay? If you have any questions, just interrupt. The most important part in functional rehab is also you have to deal with the psychological and social considerations are big. The anxiety, the deprivation, the apprehension, and of course gaining their confidence and motivation to attain it. The longer they're out of work, the longer they stay out of work, the most likelihood that they're not going to go back to work is high. So this is a big component. If you can get back their confidence, back their motivation, back and reduce their anxiety and back their strength to go back, the quicker you do it, the better it is for the outcome in the long term. Designing a functional progression is really very difficult. It is really doctor or rehab, physical therapist, occupational therapist really dependent and needs to be very creative because each person's need is different and each person's injury is different, and the limitation is by what the ability of the patient can do, whether it's limited by their psychological state or by the injury itself. So it just has to, you can't just say A, B, C, it's not going to fit everybody. So basic guidelines, you review the patient, you review what their expectations are, you look at the demands of the situation, you analyze all of it, and you make a goal, and you set the program to fit their ability to function. If it's their goal is to sit in a chair to type and do their computer desk, then that's their goal. They'll be able to use their hands to function that way. If their goal is to run and be back to the high level of the professional athlete, then their goals are different and their program is totally different. The goal in functional rehab is to go back to full activity. Basically, most important, the patient has to feel ready. You could do everything. You could assess them. You could have, like in an athlete, you can assess them. They could be tip-top shape. I mean, their muscle strength is 100%, their agility is 100%, the capacity to do the work is 100%. But if they feel that they're not ready to go back, whether it's because of their psychological feeling of stress, anxiety, apprehension, whatever might be the cause, then they're not going to be able to go back. So the patient has to be prepared to be ready to go back. And the other criteria, in order to go back to full-time, a physician has to release them to work. They have to be pain-free, and they have to have normal range, of course, strength, and they have to be able to complete the tests that is set for them as in functional rehab. Some of the testing is basically to determine the risk of the injury, whether it's due to limb asymmetry, to provide an objective measure of progress, to measure the ability of the individual to tolerate the exercises in the program, and indirectly to measure the strength and the power, the agility, their functionality in overall. Both of these functionalities, not just to assess one type of function, but to address total picture of the patient's ability to compensate and allow to follow through with whatever their job requires, their sport requires, or their vocational position of the job needs to be done. So it's all patient dependent, person dependent, and injury dependent. The limitation of the testing, it might be because it's due to the lack of the ability of normality values or the pre-injury baseline values for comparison. So if a physical medicine rehabilitation doctor sees a patient for functional testing, they usually see them after the injury or after the event has occurred. They don't know what they were before. You only go on hearsay. The patient states that was able to do so and so much. Now I can't do this. So it's really, you only can see what it is at that point in time that you're examining them, and it's very hard to understand what they were before. So basically, in the functional testing should easily, once you've done it and you've written out the report, should be able to be understood by anybody, including the Human Resources Department as well as the patient themselves. The biggest thing you have to consider in the testing is time. Time is important. The longer it takes for the patient to go back, the most likelihood they're not going to go back is high. Vocational rehab, it's basically to serve the eligible people for disability, obtaining or retaining employment is with abilities, interests, of limitations. It's basically, are they going to be impaired? Do they have disability? And you're going to meeting each individual's need for rehabilitation, managing their financial resources that are reasonable to a certain degree. So functional is a little different. If they stay out of function because of an injury and they went into rehabilitation, they're getting exercises and everything else, and they can't go back to work, then you start to look at them as the vocational rehabilitation and on determination whether they have impairment, disability, is it permanent, is it temporary, and basically to be eligible for VR services, there has to be a physical or a mental impairment. So now with vocational rehab, it's not only the physical, but mental issue plays a big role too. People do attain disability because they have mental impairment or impairments, and they don't have to have any kind of physical noticeable impairment. So this, in order for these services to be successful, main goal always is to obtain and retain employment. In every one of these vocational and functional rehabilitation services, the goal is the timeline is very important. The goal is to get the patient back to being a productive person in the environment, get them back to be employed, to initiate services and not be on disability permanently. I'm not going to go through all of this. Basically, this is just a straightforward definition on what impairment is by the Social Security Administration. An impairment that results from anatomical, physiological, psychological abnormalities which may be shown by medically acceptable clinical and laboratory diagnostic techniques. States that a physical or a mental impairment must be established by medical evidence consisting of signs, symptoms, and laboratory findings, not only by the individual statement of symptoms. This is a direct definition from Social Security Administration for an impairment is. So it's very broad. So it can be from a mental impairment, it could be from a physical impairment, but it has to be provided with evidence, not just the patient saying so. Disability, by definition, the inability to engage in any substantial, gainful activity by reason of any medically determinable physical or mental impairment which can be expected to result in death or which can last or can be expected to last for a continuous period of not less than 12 months. Workman's compensation, which we see a lot in PAC, usually defines as disability as a reduction of a wage earning capacity as a result of an injury, illness, or occupational disease that arose out of or in the course of employment. So workman's comp is during an injury or an event that occurs while you're working. Disability from other reasons, from from Social Security, is that it occurs outside of that parameter. And it has to at least last 12 months or more. The difference between impairment and disability. One individual can be impaired significantly but have no disability, while another person can be quite disabled with only limited impairment. Disability can be temporary, permanent, or partially or total. What does that mean? A patient who is in wheelchair bound, has a spinal cord injury, and is pretty much impaired, is wheelchair dependent, maybe on O2, whatever, but is able to type, is able to work. There are many cases where they can go back to full-time employment and do computer work. They're not on disability. They're impaired, but they're not totally disabled, to not able to work. They are able to work full-time. So if we went over what workman's comp is, it's during an event that occurs during the job. Fitness for duty evaluation, which is required by a physician to release a person from being on disability, whether it's temporary or partial situation. So it's just just a letter of a word. It could be written on any kind of small pad, whatever, but it needs to be done by the physician and sent to the employer that the patient is able to go back to full-time work without any limitations, and sometimes with limitations. Functional capacity evaluations are frequently performed, can be done by physical or occupational therapists, and it can take hours. A true disability functional testing should really be done by a physical therapist or occupational therapist. And there are places where they really do it appropriately. They have the setup where they reenact or have a modular, somewhat similar to the occupation that the patient is supposed to be doing, whether it's physical labor, whether it's computer. So they test the patient's ability to be able to perform that, to weighting a certain amount of weights, to range of their arms. It takes hours to do it. A true test is hours. And technically, when you fill out these forms as a physician, they have the degrees on which the arm can be ranged. You have to measure them. You know, the degrees the legs can be extended, the amount that you can bend over, the degree that you can bend over. All of these really have to be measured to be an appropriate and a technically complete evaluation. That's why I don't do it. Performing the impairment rating is more complex, so we went over that. It takes a lot. You basically have to do a big assessment. The comprehensive review should also include the physical examination, the assessment of the motivation of the patient, the credibility of the alleged pain or other limitations, and the assessment of the cause. It is more complex than just a little piece of saying that the patient has, yes, on disability, cannot work for 3 days, 5 days, 6 months. So basically, to do a proper job, you really have to send them to, there are doctors that do disabilities and institutions of physical therapy, occupational therapists that do these evaluations, and they're really the best ones to do them. Any questions?
So if somebody comes and asks you to fill out a disability form, do you refer them to?
I tell them I don't do disability.
Okay.
I tell them I give you my last progress note and all the notes that you want that I have here, if you want to take them. Most of the time, from my experience, 90% of the time, Social Security Disability has accepted it. And they have not asked for any forms. Now, a couple of times in a row, I've gotten 20-page letters of forms to be filled out, and I write back, I do not do disability. There are doctors out there, and it's most of the time is cash basis, who do all of this, who sit down and spend the hours needed for it. Well, I told our front desk that we should write it.
Yeah.
Disability is not done.
Right.
But,
A lot of things that front desk.
and usually what the patient does is that we finish the whole thing and everything, and they give it, and before they're just about to leave the door, oh, doc.
I got the papers, yeah.
It's always just about as they're about to leave. Or the other one is for handicap permits.
Yeah. Same thing, you don't do it.
I've done them twice.
Okay.
If I really generally believe that the patient qualifies for it, I will.
But what if they ask, like, I need a couple days off of work? Any doctors know?
After an injection, maybe,
Okay. Right.
but not routinely.
Right.
Then I said go to your primary care, and they can give you,
Sure.
because I can't qualify pain totally.
Yeah.
And if it's that much severe pain that you can't go to work, maybe we need to admit you.
That's a problem, yeah. Okay.
I mean, if that pain is that incapacitating and that severe, they might need to be admitted, not to be out. And usually when you tell them that, they say, no, 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 oh, it's okay.